Very much, Mira, for your invitation at this meeting. It's a pleasure for me to be here in Africa. I'm a friend of Dr. Masalu, with whom I'm cooperating about from 16 years or 14 years. And I'm proud of the activity that Dr. Masalu did in Mwanza, where he's growing very fast, a very important cancer center. My speech regards the rationale, indications and results of radiochemotherapeutic combination. And to be sure to maintain the time that Mira gave me, I will read my speech. So, multimodal approach has been key to improve outcome after oncology treatment during the past decades, and among the pillars of treatment, radiotherapy and chemotherapy are up to date two which have emerged to be especially important when twinned. For over a century, radiotherapy has been mainstay of non-surgical treatment in oncology, and since the 60s, chemotherapy has gradually been taking a comparable role. So, combined chemotherapy with radiation was applied in 70s for the treatment of Ewing sarcoma, and the results suggested that the potential for an increased cure rate with this approach. So the evolution of chemoradiotherapy was mostly empirically driven, rather than relying on scientific rationale, and this is a limit of radiochemo combination, based only on empirical data. Today, chemoradiotherapy is the standard modality for most patients with local advanced solid tumor due to better control of local regional disease and prolonged survival. So we expect from radiochemotherapy both results, either the local control or the overall survival improvement. But as molecular target drugs are more and more integrated in chemoradiotherapy combination, it is crucial a good understanding of the mechanisms of chemoradiotherapy for the rational development of future combinations. There is no more space to combine empirically this kind of treatment, because the toxicity could be very, very dangerous. So my presentation aims to review the rationale behind the combination of radiotherapy and chemotherapy, two modalities which form the mainstay of the treatment of most solid tumors. The rationale, the first part of rationale, is this, and it regards adding chemotherapy to radiotherapy is done with the intention to improve a very important topic, a good therapeutic ratio, which is the ratio of the dose that produced a specific probability of normal tissue damage and the dose that provides the same probability tumor control. In 1936, Holtzhausen described the tumor control probability, TCP, and normal tissue complication probability, NTCP, as a function of the physical dose. The balance between these two parameters is very important to have a good therapeutic index in cancer treatment. The therapeutic index can be increased by concurrent chemotherapy when the treatment leads to a left shift, the long arrow, of the TCP curve, and ideally not or minimally impacting on NTCP, short arrow, as you can see in the figure. So we can have three different conditions. One is a possible competitive effect between chemotherapy and radiotherapy, or a simple additive effect, or better, a synergistic effect by the combination. Chemoradiotherapy can improve the therapeutic effect strategy in two main ways. The spatial combination, you can see this topic in the left of the slide, and in-field cooperation, as you can see in the right part of this cartoon. Spatial cooperation describes the different treatment modalities' impact on distinct territories of disease. Radiotherapy acts in the circumscribed area, a target volume, loco-regionally, to eradicate the tumor contained in the area, whereas chemotherapy tackles the disease beyond the target volume or radiation, and this requires no interaction between two modalities. So, spatial cooperation relies on differential toxicities of radio and chemotherapy to use both modalities at effective dose. And the spatial cooperation is a very important rationale for the combination, and the end point to be reached by the combination observing this kind of rules are very strong endpoints. Local recurrences in breast, for example, or disease-free survival, or overall survival together. But in 2007, Benz and others proposed for more mechanism of drug radiation interactions, apart spatial and in-field cooperation. Cytotoxic enhancement, biological cooperation, temporal modulation, and normal tissue protection. Rational normal tissue protection. In this case, according to Steele and Peckham's concept, chemoradiotherapy can allow delivering higher dose of radiotherapy than when radiotherapy is used alone. It seems a contradiction. But up to date, this concept is limited to the use of cyclophosphamide and methotrexate and must be reconsidered in the light of new chemotherapeutic drugs to be combined with radiotherapy, particularly molecular and immunotherapeutical agents. How much chemotherapy combined with radiotherapy could protect normal tissues is an open question up to date. Cytotoxic enhancement is a very important topic on the basis of whom many treatments are based. It can be defined as the enhancement of cell killing through the alteration of the induction or repair of DNA damage. And to achieve cytotoxic enhancement, chemotherapeutic agents should be present at the time of irradiation as they are modulating the initial stage of radiation-induced cell killing or repair. And this effect may be obtained by concurrent chemoradiotherapy. Another important topic is the biological cooperation. This strategy is aimed to enhancing cell killing or delaying tumor regrowth by modulating different mechanisms and targeting distinct cell populations. A good example of biological cooperation is combining radiation with agents which can enhance the radiation response by selectively eliminating hypoxic cells or sensitizing them to radiation. Bioreductive agents such as tirapazamine and mitomycin C selectively target epoxy cell by being metabolized to toxic intermediates under hypoxic conditions. Biological cooperation must be more and more studied in the light of the new biological agents in treatment of cancer. Temporal modulation. This is a very important topic because it conditions the timing of the treatment. Temporal modulation defines the interactions between molecular target therapies and radiotherapy. It is aimed at enhancing the response of the tumor to radiotherapy via affecting DNA repair, neoxygenation, cell repopulation, and redistribution. The combination of insulin high growth factor 1 inhibitors, such as cetuximab, with radiation is a good example of biological cooperation. And since biological processes are not equally active in malignant and normal cells, and this is the important observation, tumor control can be enhanced by modulating this mechanism, such as changing the dose per fraction, the time interval between fractions, or overall treatment time. Drug and radiation should be given concomitantly or in a rapidly alternating schedule. Taking in mind all these considerations, basic consideration, the choice of chemotherapeutic agents in chemoradiotherapeutic combinations is made according to specific mechanisms of action related to DNA damage due to radiotherapy. So, cisplatin is one of the most used drugs in this combination, acts mainly by creating multifunctional adduct and intrastrand or interstrand crosslinks following interactions with the nucleophilic sites of DNA, enhancing cell killing effect of radiotherapy, inhibiting DNA repair. It is particularly indicated in concomitant radiochemotherapy regimens. Fluoropyrimidines, gemcitabine, and hydroxyurea are among the most potent radiosensitizers, and targeting S phase of the cell cycle can radiosensitize tumor cells through repopulation and synchronization of the same cells. Taxanes is one of the rational radiological rationale for combined taxane with radiation is the ability of these agents to cause the cell arrest in the phase G2N of the cell cycle. In this phase, radiotherapy is particularly active. Moreover, taxane have been shown to enhance other phenomena, such as the tumor reoxygenation following tumor shrinkage. Recently, taxane are also attributed to be able to influence neoangiogenesis in the tumoral tissues. Now, coming to the clinical impact of the previous considerations, we know that chemotherapy may be administered before in neoadjuvant setting, during, concurrent, or after the course of radiotherapy. Induction chemotherapy aims to eradicate small micrometastases of tumor and to reduce the size of the primary tumor that will be irradiated. And despite the good rationale, the results of randomized clinical trials of this modality have not been encouraging. This approach is preferred in organ preservation programs, particularly in larynx, hypopharyngeal carcinomas, as has been shown by ERTC trial 24891. If we will try to defend the induction chemotherapy treatment, we could consider that it could be useful when there is the need to optimize patients' medical status, when the tumor has a very high potential for metastasis or oligometastasis, when is an unavoidable delay in starting radiation, and in markedly advanced primary disease and or neck disease. This is the only situation where induction chemotherapy could be very, very useful. Adjuvant chemotherapy, you know what it is, and I don't spend time for this. But the setting where adjuvant chemotherapy is very important is the setting of nasopharyngeal carcinoma. All of you know the important work of Al-Sarraf, who randomized patients to receive only radiotherapy or radiotherapy plus cisplatin for 3 cycles, followed by cisplatin plus 5-FU for 3 cycles. And the results were dramatically important. As you can see, either for PFS or DFS or overall survival, chemoradiotherapy plus adjuvant chemotherapy was highly significantly better. And CCN guidelines suggest in this kind of tumor, the concurrent chemoradiation plus 3 adjuvant chemotherapy is the accepted standard for T2 and 2 stages. Concurrent chemotherapy, this is the most important topic. Concurrent chemotherapy, radiotherapy has assumed a dominant role in the treatment of solid tumors. Improving local disease control is considered as the main way for concurrent chemoradiotherapy to exert its beneficial effect. But also organ preservation and the potential eradication of distant micrometastases are other clinical rationales for the use of concurrent chemoradiotherapy. A lot of settings are treatable by the concurrent combination of chemoradiotherapy. And I will not analyze all this table just to show you how many situations can benefit from this kind of treatment. But what I would like to underline is the importance of this kind of treatment in head and neck cancer. In fact, a meta-analysis regarding about 17,000 patients showed that concomitant radiochemotherapy in head and neck cancer achieved an absolute benefit of 7% at 5 years, at 2 years, and 8% at 5 years, highly in a manner highly significant versus adjuvant and neoadjuvant treatment. So we can consider the standard of care this kind of treatment. Obviously, if head and neck cancer are those who better benefit from this kind of treatment, other tumors can benefit. Non-small cell lung cancer, cervical cancer, anal cancer patients, and in resectable stage 2-3 rectal cancer, concurrent radiochemotherapy increase only the rate of complete pathological report, but with decrease of local recurrence, but not survival. This is the exception. I finished. These are the conclusions. Multimodality treatment of the majority of solid tumors is the standard care. Concurrent chemotherapy has become a standard treatment for various malignant tumors. In general, concurrent chemoradiotherapy is regarded to be more effective compared to induction chemotherapy followed by radiotherapy, and the improvement of therapeutic ratio without compromised quality of life must be achieved with the new drugs and new therapeutic modalities. And finally, the interaction between chemotherapy and radiotherapy at molecular level must be more deeply understood. Molecular predictive factor sensitivity to chemoradiotherapy are needed and should be standardized. Target agents added to chemoradiotherapy combinations should further improve efficacy, and chemopreventive agents of chemotherapy toxicity must be developed to reduce high-grade acute and late toxicity. Thank you very much.